I think what's tricky is even when you're assessing itch and a lot of these things is that, as clinicians, we catch a patient in a cross-section of time. And, I often have the experienced patients say, doc, I look good today, but yesterday I was a mess, or a week ago I was a disaster and had to take prednisone. So I think it's hard when we sort of pigeonhole a couple of measures where patient might fall just short when if you would have gotten them a day or two earlier, they would have met criteria. And so I think it's just, I feel like if we limit to one measure only, like body surface area, there may be patients who desperately need these drugs who may not get it. And so if we could have maybe some more options, or that we agree upon.
I could see that there could be a combination of things as part of utilization management, as long as it doesn't get overly complex. But we do already have utilization management and prior authorization criteria, and you probably do a lot of these for us. Where we'll ask them if you have this or that, or you have these other two. So as long as we can define what each one is to some reasonable extent. Then you can look at that, and so we might not need a hard score like a 4 or 12.5 or something like that. But if we can say, for example, as you'd already put it together, as a small number of lesions, but they're terrible. A large body surface area, whether it's terrible or not terrible, it's large, and then, patients' other symptoms like pruritus and you don't even have to ask about sleeping. If we know about itching, we probably know a lot more about that.
All right, so let me kick this back to Jeff. What are, in your view now, okay, I'm not going to make you speak for the entire profession, but in your view, what are the most important aspects to managing this disease? How do you overcome these challenges?
Well, I think we talked about a lot of this already. I think the extent of the disease, certainly when you're thinking about a systemic agent, is going to be crucial. The itch is going to be, super important. And I think there's some harmony in terms of our discussion in that we're going to try some of the topical, cheaper stuff out there already first. So, I think in that sense where there's harmony, I think there's some of the nuances that probably need to be hashed out. But I don't like the idea of using an easy or a score in clinical practice, because I don't think it's something that certainly primary care doctors, but even the average dermatologist are even familiar with, let alone how to use in a reliable way. So I think the extent, body surface area, how itchy, how intense, and then how miserable the patient is, how much it's affecting them.
There's a misery index out there somewhere?
Well, if the patient is going to head to the point of disability, which I have a lot of patients who are currently on disability, partial or full, because that's how bad the disease is for them. Things like that I think need to be taken into the equation.
And by the way, this comes back to who's going to pay, right? Because if they go on disability, then you're not paying them.
Yeah, but that's what I'm talking about with these secondary measures is functionality and things like that. They're important, So I want to discount that. But when you're coming in, when you're saying this, hey, this improves sleep, I need to understand what that means in terms of the disease state, not just that it improves sleep.
Okay.
So that was the point on that. But I think this is to kind of from a payer perspective in response to that question. It's exciting to have new drugs that actually treat the disease state rather than the symptoms. But the challenges here are going to be, now we've gone from a disease state that we're really not paying for right now, or we don't understand how we're paying for it because it's generics over the counter, to something that's potentially going to be very expensive. So the challenge is how you pay for that, and how do we come to a consensus on where these drugs fit.
Cheryl, you guys.
Yeah, I was going to say, I think another measure that could be taken into account with these patients is previous or concurrent therapies that you're using to control your atopic dermatitis. Right? Or what are you using? Because that would be sleep therapies, antidepressants, things like that.
That all stirs in the pot.
Along with the functionality, to give a total picture of this patient, that as we're advocating on behalf of the patients to, make the case for drug therapy, you have to look at that 360 view of that patient.
I mean, if you could start to peel off some of those other therapies, I guess is what you're saying?
Right.
Doesn't that reduce the overall cost? Maybe it's more with the new therapies, but not quite as much more.
Yeah, I don't disagree. I understand where you're coming from, but again, let's use asthma as an example. I mean, if the value proposition is I can reduce one rescue med a day, a puff, versus use 3 instead of 4, great. But where's the value prop in that? So again, I don't. If the value prop here for let's just say a $25,000 a year drug is that I'm avoiding a $4 a month generic antidepressant, then we need to understand where that fits. That's not a value prop. The value prop is the disease state's changing and these things are changing and the patient's getting better.
Okay.
It's not that I'm avoiding a $4 a month generic antidepressant.
That, that's a very subtle statement. If I understand what you're saying, is how's the patient doing? Is the patient better? You're willing to pay for something that's going to make a patient's life better,
Absolutely.
but not for something that you can't show makes the patient's life better. Is that fair?
That's fair.
I like that. That's nice. Does that make sense to you?
That makes sense.
All right, so now.